Welcome to the CINP Leader Panel. My name is Siegfried Kasper. I'm the president of CINP, and I have the great pleasure to introduce my colleagues, Professor Gobbi from McGill University in Canada and Professor Krystal from Yale University in the United States. Today we have the topic of the role of cannabinoids in psychiatric patients. I would like to ask Dr. Gobbi to start with her point of view.
Okay, the topic of cannabis in psychiatry is very complex because there is a bad side and a potential good side. I start with the bad side. So we have now more hundreds epidemiological studies that have demonstrated that the THC, the consumption of THC, especially during adolescence or early adulthood, increase the risk of schizophrenia and bipolar disorder in people that have a predisposition for this disease. In particular, anticipate the first episode of psychosis, the first episode of mania or depression, as well as the prognosis of schizophrenia and bipolar is worse if people consume cannabis. Then we have also recent data, one data also from a laboratory, where we have demonstrated that cannabis consumption in adolescents also increase 40% the risk of depression and the risk of suicidality, even in people that were not predisposed for depression. So there is something very serious about cannabis and the consumption of cannabis during adolescence. Moreover, also there are evidence that THC can also increase some risk of anxiety, can also make worse the PTSD. But on the other hand, in North America, now it's in Europe, more and more people want to use THC as well, cannabidiol, that are the two components of cannabis, for example, to treat anxiety, to treat insomnia, also to treat PTSD. So right now in psychiatry, we have no clinical trials that have demonstrated that THC or cannabidiol is good for depression or is good for anxiety. We have only anecdotal evidence. So doctor, in particular psychiatrists, should be very, very careful before prescribing a patient CBD or THC. Now, for example, in Canada, we have this absurd situation where people with bipolar disorder or anxiety, as a first medicine, they take cannabidiol to treat bipolar disorder or to treat anxiety, and don't take the first line treatment or second line treatment. So we found that patients are not really treated, are not cured, and are at very high risk of relapse, of worsening their situation. And I would like also to say something that the people don't maybe understand. Now is the first time in the history after the Second World War that we have medicine that are not approved by FDA or EMEA or Health Canada. So we are in a very paradoxical situation. Doctors are pushed by people to prescribe drugs for which there is no evidence-based data. So this is a very critical situation, and we should be aware about our medical practice.
Thank you very much for this very clear statement. Professor Krystal, what do you think?
Well, I very much appreciate Dr. Gobbi's perspective on this. I think it's a terrible problem that in many parts of the United States and in Canada, that the government has legislated a medical practice in advance of having the data to support the prescription of medications for the treatment of medical and psychiatric disorders. And I'll just highlight, I'd like to come back to your comment about post-traumatic stress disorder. So there are two very small pilot studies of cannabis or THC for PTSD symptoms that are equivocal in their findings. But there is a very large-scale epidemiologic study of the veterans in the VA system in the United States across the country which shows that in people with post-traumatic stress disorder, use of cannabis is associated with worse outcomes for PTSD.
Yeah.
So the question is, in the state of Connecticut where I live, despite testimony given to the state government that there were risks associated with use of cannabis in people with PTSD, they still went ahead to pass the legislation that allowed medical cannabis for PTSD, and I think that's a big problem. I think one of the urgent issues for the field of psychiatry is to test the effectiveness of medical cannabis and THC in rigorous, well-powered clinical trials so that we can more adequately evaluate the safety and effectiveness of these substances in the treatment for psychiatric disorders. That we have to anticipate that there will be a high level of use in these populations, and I don't believe we are prepared to understand what the implications of that be. The second issue is that we have no effective treatment for cannabis use disorders. No medications, very little in the way of cognitive and behavioral therapies targeted to helping people to manage cannabis use. And so we're creating tremendous access to these substances without giving the medical community the tools that it needs to help people manage the consequences of free access to cannabis. So I think that this is a very troubling time where we are exposing people to risks without having the means to support people that we are putting at risk. So I'm very concerned about this.
So I think this is a very important statement, and in Europe there are some countries where you can freely have it, like in Netherlands, in Austria, luckily, or in Germany you cannot have them as yet. But there's still a huge demand on patients. They constantly ask us, can't we have this? Why are you so old-fashioned? Why don't you prescribe it to me? And if we don't prescribe, they just get it from the internet from somewhere. So what I hear from you, it's very important that should go through a medical evaluation. And we have an eminent researcher in our university, Professor Harkani. He looks at different animal models, and he very nicely describes that when the brain is still developing, and this goes also through adolescence, then the use of cannabinoids, including cannabidiol, is very bad. But let me ask you, there are also some studies have been undertaken in schizophrenia. What came out of these studies? There are already 10, 15 years. Was a study for cannabinoid?
Yes, if I remember, actually Sanofi about 15 years ago tried the rimonabant in schizophrenia. They did a phase 2, maybe as a phase 3, and they found no results. With results. Rimonabant is a CB1 antagonist. Very recently was just published another paper, brain imaging, when they found in schizophrenic there is a downregulation of a CB1 receptor. So we know that there is something between cannabinoid and schizophrenia. In fact, 95% of people with schizophrenia smoke cannabis. So there is a particular link, but we still don't know how we could exploit the cannabis medicine for schizophrenia.
It's my understanding that there was at least one positive trial with cannabidiol as a adjunctive medication for the treatment of schizophrenia. And there are other cannabinoid substances such as a fatty acid, amino acid hydrolase inhibitor, FA, the enzyme breaks down anandamide, that might be another strategy which could be explored in schizophrenia, but these are all relatively new areas of research.
There is just a new study that was published 2 years ago where the FH inhibitors, the inhibitors of the enzyme that break apart anandamide, was positive for the withdrawal symptoms from cannabis. So this may be a new drug in the future that can be used for cannabis withdrawal.
But as both of you mentioned, bipolar disorder on the one hand side, schizophrenia on the other hand side, are so serious illness that we should not, we should take very much care that they should receive the medication which has been properly studied.
Yes.
And not given as an add-on just based on one experience on the slow population, right? So what about pain? So sometimes patients also, they approach us and say, well, for pain, I don't suffer from bipolar, I don't suffer from schizophrenia, I'm 60 years old, so can't you prescribe me cannabidiol?
No, actually, in animal, we have demonstrated that cannabidiol is good for neuropathic pain. Not only alleviate pain, but also the anxiety and stress associated to pain. But these studies are done in animals. We need clinical trials to demonstrate that cannabidiol can be really effective also in patients with neuropathic pain or fibromyalgia.
And probably these doctors using this medication, usually anesthesiologists or some other people, they do not know our data on patients with pain and do not know our data also on anxiety disorders.
Yeah. And also don't forget that people use cannabidiol for anxiety pain where the placebo effect is very, very important. So we don't know if it's a placebo response or it's really a cannabidiol response. So for this reason, it's very important to have a phase 2, phase 3 clinical trials.
Right. I think that's the general message which we get here from two experts from different parts of the world, which I also happily join in, that this type of medication needs to be thoroughly studied before our patients are exposed, and specifically those human beings which still develop their brain, like in adolescence, are a great danger receiving this cannabidiol and THC, because this might also change their metabolism in the brain to the bad side. So I thank you very much for joining in.